This topic is oral agents in the treatment of adults with type 2 diabetes. My name is Bobby Farah. I'm a clinical pharmacy specialist practicing in an outpatient academic family health center here in Pittsburgh. I'm on faculty at the UPMC St. Margaret Family Medicine and Pharmacy Residency Program, and I'm also on faculty at the University of Pittsburgh School of Pharmacy. After reviewing the information covered in this presentation, participants should be able to identify the various oral treatment options available for treating type 2 diabetes, including their expected lowering of A1Cs, their mechanism of action, general precautions, and side effects. You should be able to describe the advantages of using different drug combinations related to their combined effect on A1Cs, their side effect profiles, and cost. And looking at patient-centered diabetes goals, be able to use the patient-centered goals and identify diabetes treatment medications related to these goals. The oral agent classes used in the treatment of type 2 diabetes that I'm going to review today are the insulin sensitizers, including metformin and the TZDs, insulin secretagogues, including sulfonylureas and the meglitinides, DPP-4 inhibitors, alpha-glucosidase inhibitors, sodium glucose co-transporter 2 inhibitors, dopamine agonists, bile acid sequestrants, typically used for cholesterol. And I'm going to review one notable injectable non-insulin option, the GLP-1 receptor agonists. It is very helpful to relate the mechanism of action of medicines to the multiple defects that lead to type 2 diabetes. This can help in understanding why some drug combinations might not work as well. For example, using two secretagogues like a sulfonylurea and a meglitinide. And while some combinations like a sulfonylurea and metformin might make good sense by targeting multiple defects that leading to hyperglycemia. So 4 common defects related to hyperglycemia that medications can target include abnormal islet cell function, which is generally progressive with diabetes. Pancreatic cells increase glucagon, which further increases hepatic glucose production. Insulin resistance in target tissues, including the liver, the muscle, adipose tissue, and the myocardium, and abnormalities in the incretin system. This next image here depicts the 4 defects I just reviewed that are circled here, with some additional areas that medications can work to improve hyperglycemia. And these improve the gastrointestinal system, the carbohydrates and the glucose that are taken in by the diet, appetite control, increasing glucose excretion, and diverting excess lipids from non-adipose tissue to adipose tissue and lipotoxicity. Now, both the American Diabetes Association and the American College of Endocrinology recommend metformin as a drug of choice for treating all newly diagnosed type 2 diabetics. It decreases hepatic glucose production and to a lesser degree decreases intestinal absorption of glucose and increases peripheral glucose uptake. It lowers A1C between 1% and 2% and is generally considered more durable than other oral agents. It is weight neutral or can cause a small loss of weight. Now, other significant advantages include it being very inexpensive, it rarely causes hypoglycemia, and the UK PDS trial demonstrated a lowering of myocardial infarctions and all-cause mortality with metformin. The most common side effect are gastrointestinal side effects, which include diarrhea, nausea and vomiting, and abdominal pain. This is generally dose dependent and can be managed with starting low on the dose and titrating very slowly. You also may use some supportive measures. For example, a patient with diarrhea with metformin, despite continued use, might benefit from increased fiber in their diet until they develop a tolerance to the medicine. Alternatively, using an extended release formulation of metformin may improve some of these gastrointestinal side effects. Metformin can cause lactic acidosis in patients with severe renal impairment and can worsen recovery from elevated levels of lactic acidosis that are caused by conditions of tissue hyperperfusion, such as unstable heart failure, severe lung disease, shock, and sepsis, as well as decreases in lactic acid elimination that it can be seen with alcohol abuse and liver disease. And keep in mind that the signs and symptoms of lactic acidosis include nausea and vomiting, abdominal pain, tachycardia, and increased respiratory rate. Additionally, metformin can cause a decrease in vitamin B12 levels. The primary contraindication of using metformin is patients that have a GFR of less than 30 mLs per minute. The United States FDA package insert clarifies a severe renal impairment as a serum creatinine of greater or equal to 1.4 in women and greater than or equal to 1.5 in men. In patients with a GFR that is reduced between 30 and 45, it's recommended that you decrease the dose by 50%. So for example, if a patient is on 1 gram BID, their dose would be reduced to 500 milligrams BID. In patients with a GFR of 45 to 60, it's recommended that a metformin dose doesn't need to be adjusted, but continued renal monitoring would be warranted. And keep in mind that metformin needs to be discontinued in patients that are undergoing IV contrast studies. You need to hold metformin the day of the procedure and not to restart until 48 hours later. It takes 2 weeks to see the full effect of a metformin dose, so you're titrating at least every 2 weeks. A common regimen to initiate as far as immediate release is to do 500 milligrams once daily with your biggest meal of the day for a week. And if patients are tolerating it from a gastrointestinal side effect, they can self-increase to 500 milligrams twice a day. And patients who are on 500 milligrams twice a day, we're told to tell them to take it about every 12 hours. So with breakfast and with their evening meal, I usually counsel them to get your food and you take it with the first bite of your meal. And the maximum dose is 1,000 milligrams twice a day. If you're using extended release metformin, it's once a day with breakfast. Again, you're just taking it with the first bite of your meal, and the maximum dose of the extended release formulation is 2,000 milligrams once a day. The thiazolidinediones are the next class we're going to review, are TZDs. They're primarily known to enhance insulin sensitivity of muscle, fat, and liver tissues by shifting fat storage cells. And they also reduce hepatic glucose production. There are 2 medications in this drug class, including pioglitazone and rosiglitazone. And due to increased concern and risk of possible myocardial infarctions, rosiglitazone was restricted in our access program by the FDA, although that restriction has recently been lifted. Pioglitazone is generally the only TZDs that are going to be prescribed in 2014. Pioglitazone is highly protein bound. It's metabolized by the cytochrome P450, 3A4, and 2C9 enzymes. And other medicines that you might use with it, whether it's a strong inhibitor like gemfibrozole or an inducer like rifampin, might cause you to either increase or decrease the dose of pioglitazone. So for example, gemfibrozole is a strong inhibitor, and you might, if you're using gemfibrozole with pioglitazone, you might reduce the dose of pioglitazone to 15 milligrams daily if you're using them concomitantly. TZDs lower A1Cs by 1 to 1.5%. And it's been stated that this drug class has a particular durable effect, which means that its positive effects on treating hyperglycemia stay with the drug after continued years of use. Its other advantage is that it rarely causes hypoglycemia, and it is available generically. The most common side effects are volume retention, which can be demonstrated as peripheral edema, macular edema, and subsequent weight gain. These side effects appear to be dose-related, so decreasing the dose may help with that, and they also can be supported or managed with concomitant diuretic use. TZDs are contraindicated in patients with New York Heart Association class 3 and 4 heart failure. Less common side effects and precautions to keep in mind are some liver injury, and pioglitazone has a relatively small propensity to increase liver enzymes, which is much different than the first TZD that was approved in the late 1990s called Resulin or troglitazone. Troglitazone caused idiosyncratic hepatotoxicity and deaths from liver failure, and that was removed from the market in the late 1990s. But pioglitazone still needs to be looked at as far as LFT function. You're looking for an ALT or an AST of greater than 3 times upper limit of normal would be an area to be concerned, and a total bilirubin of more than 2 times the upper limit of normal. TZDs can also increase fractures, which is thought to be caused by potentially decreasing osteocytes and the function of osteoclasts and osteoblasts. And there's a risk of increased bladder cancer with pioglitazone, and as mentioned previously, an increase in cardiovascular risk and myocardial infarctions on rosiglitazone. So most patients, because of this drug class's durability, if patients are doing well on the drug, they will be continued on it unless any of these significant adverse effects would arise. But generally, the risks and the benefits need to be weighed as to whether they're going to be added on in this current course of therapy. The dosing, pioglitazone is dosed 15 to 30 milligrams once a day. Its maximum dose is 45 milligrams once a day. We counsel patients to try to take it the same time every day, with or without food, and most patients will take it with their first meal of the day, for instance, which would be breakfast. And TZDs have a particularly long time to take full effect. So metformin takes 2 weeks to see the full effect of that particular dose. TZDs take at least 4 to 8 weeks to see the full effect of that medicine in that dose in particular. So be careful not to titrate any faster than 1 to 2 months. Sulfonylureas. These are considered insulin secretagogues. They stimulate insulin secretion independent of food intake. So you don't want to take these medicines if you're missing meals. All agents in this drug class are generally equally effective in lowering blood sugars if they're used at equal potent doses. The first generation listed here are seldom used because of their lower potency and increased risk of hypoglycemia. Of the second generation sulfonylureas, glipizide, glimepiride, and glyburide are the 3 that are available. Sulfonylureas are metabolized in the liver, and glyburide has active metabolites, which increase its risk of causing hypoglycemia. Agents with active metabolites that are renally excreted should be used with caution in patients with compromised renal function, and that also would include glyburide. The half-life and the duration of effect are related to the risk of hypoglycemia. The half-life is about 2 to 3 hours of immediate release glipizide and about 10 hours for immediate release glyburide. Sulfonylureas are fairly effective. Their A1C lowering is similar to metformin. They'll decrease A1C by 1 to 2%. They, however, are less durable in that patients will get less effect over time, and it may be because of the sulfonylurea, or likely could be because of diabetes itself and its effect on the pancreas. Other advantages of sulfonylureas include they're very inexpensive, and then long-term, the UKPDS showed that they decrease microvascular risks. The most common side effects and concerns are hypoglycemia and weight gain, and less common are rash, headache, nausea and vomiting, and some photosensitivity. And you want to be really careful to use these agents in patients with hypoglycemia unawareness. So we're looking at the elderly patients, patients that may be on medications that block some of the symptoms of hypoglycemia, like beta blockers. And you also want to be very careful in using these agents in patients who have poor renal function, because again, the risk of hypoglycemia is stronger. Glipizide is generally the safest of these agents to be used in people who have reduced renal function. And so I think of glipizide as being I would use glipizide over glyburide. It takes 2 weeks to see the full effect of using a certain sulfonylurea and a certain sulfonylurea dose. Glipizide, again, is the most common sulfonylurea used and recommended. In the immediate release form, 5 milligrams daily is started, and you might want to start a little bit lower in the elderly at 2.5 milligrams daily. And then you can work up to 5 milligrams twice a day and 10 milligrams twice a day being the max dose. And then you're going to take these BID about 12 hours apart, so with breakfast and with dinner, and particularly to counseling patients that if you're going to miss your meal, you should skip your dose. The extended release formulation is dosed once a day, and it's usually given with the first meal of the day, so it would be breakfast. And same thing with the immediate release. If you're going to miss a meal, you skip that dose, and you will take the dose when you eat your meal. So for example, a lot of diabetics might say, I don't eat breakfast, or I missed breakfast today. They shouldn't take their extended release glipizide without a meal. And so if they eat their lunch a couple hours later, that's when they should take their extended release glipizide. Okay, the meglitinides. This is another form of a secretagogue. It's structurally different from sulfonylureas, but they work on pancreatic beta cells as well, leading to stimulation of insulin secretion. Unlike sulfonylureas, though, the presence of glucose is needed to stimulate insulin secretion. So the risk of hypoglycemia is generally less. And they're not recommended to use in combination with sulfonylureas. The two meglitinides that are available are repaglinide or Prandin and nitaglinide or Starlix. Their efficacy in lowering A1C is less than sulfonylureas, and they're slightly different compared to the two that are available, with repaglinide being slightly more effective than nitaglinide at A1C lowering of about 1% versus Starlix is at about 0.5%. Again, in the kinetics compared to sulfonylureas, these are shorter acting. They have a very rapid absorption. So their peak is 30 to 60 minutes and a very short half-life, 60 to 90 minutes. They need to be taken multiple times a day, generally 3 times a day with meals. The most common adverse effects are hypoglycemia and weight gain, although it's less than with the sulfonylureas, and they may increase serum uric acid levels, to keep that in mind. And then the contraindications and precautions are patients with poor renal function, patients with hypoglycemic unawareness, which are your elderly, your patients who may be on beta blockers, and then caution with poor renal function, and patients with moderate to severe liver disease. Repaglinide is dosed 1 or 2 milligrams 3 times a day with meals. If you miss a meal, you skip a dose. Same with nitaglinide, as 3 times a day with meals, and if you miss a meal, you should skip a dose. This class is more expensive than sulfonylureas, and generally we don't recommend it. We recommend it if a patient has failed sulfonylureas or experience postprandial hypoglycemia on a sulfonylurea. They may be switched to a meglitinide to help manage their prandial needs. You may also see a meglitinide used 3 times a day with meals if a patient's on basal insulin. So for example, a patient might be on a low dose Lantus insulin and for some reason isn't tolerating a lot of other oral therapies. You may see Prandin used 3 times a day with meals with this basal insulin, assuming that the basal requirements are relatively low and the needs aren't that high, and Prandin can still help manage the mealtime requirements. Okay, a very popular drug class in the recent years are the DPP-4 inhibitors, or otherwise known as the gliptins. And these are incretin enhancers. They inhibit the endogenous incretin from being degraded, which potentiates the glucose-dependent secretion of insulin and suppresses glucagon secretion. The four DPP-4 inhibitors are sitagliptin, Januvia, saxagliptin, Oglenza, linagliptin, and alogliptin. You need to reduce the dose in patients with renal dysfunction on 3 of the 4 DPP-4s listed here. And there are some cytochrome P450 3A4 drug interactions with sitagliptin and saxagliptin. And it's important to note that, remember the function of incretin that I showed in the first picture of this lecture, is that incretin can also slow gastric emptying and may promote satiety and maybe help patients lose some weight. Although DPP-4s are becoming increased in popularity, overall their effect on A1C lowering is relatively small compared to the other agents I'll be talking about today. But the particular advantage of them is that they're well tolerated and they rarely cause hypoglycemia. So you're kind of getting a trade-off in effective A1C lowering, but tolerability and durability is much higher. Again, the adverse effects are very low. You might want to less commonly watch out for hypersensitivity reactions and liver dysfunction. And the only contraindications and precautions right now are pancreatitis, so patients with a history of pancreatitis or elevated or severely elevated triglycerides. And saxagliptin may worsen heart failure, so some monitoring and general risk to benefit ratio needs to be managed when saxagliptin is used in patients with heart failure. These are the 4 DPP-4 inhibitors listed here and their dosage. What's nice is that they're all once-a-day medicine. We counsel patients to try to take them at the same time every day. And they can be given with or without food, but the bioavailability is a little bit better if it's taken with food. So first meal of the day, breakfast, is what I will most commonly recommend patients take these medicines. And again, they do very, very well as far as tolerability, which is a huge perk because adherence and compliance with a regimen is very important when you're assessing its effect. The next class are the alpha-glucosidase inhibitors. And they inhibit alpha-glucosidase enzyme of the small intestine to slow the breakdown of carbohydrates to glucose. The 2 alpha-glucosidase inhibitors are acarbose and maglidol. Their action is limited to the intestinal lumen. Their metabolites are excreted in the kidneys, and it's not recommended for patients with a high serum creatinine, which is defined as equal to or greater than 2. Its efficacy of A1C lowering is relatively smaller, like the DPP-4s, lowering A1C by 0.5 to 1%. The primary role of alpha-glucosidase inhibitors are for patients who have a relatively high postprandial glucose. So if your patients are checking their blood sugars 1 to 2 hours after a meal and the blood glucose level is greater than 180, that might be a particular niche for this drug class. The most common adverse effects, though, that limit its use are gastrointestinal effects, gas, bloating, abdominal pain. It can be managed, and I'll mention this in the next page, with starting really low on the dose and titrating very slowly. And the precautions, you need to caution use in people who have short bowel syndrome or inflammatory bowel disease, and patients who have increased liver transaminases, particularly with acarbose. And a lot of diabetics are told to follow a low carbohydrate diet. And so there's a question as to whether these may be less effective in patients who aren't eating carbohydrates or are eating a low carbohydrate diet. This drug class may be less effective. So like I mentioned previously, you want to start low on the dose. You want to check postprandial blood sugars to see the effect. And you want to wait at least 2 weeks before you're titrating. So acarbose. 25 milligrams 3 times a day is a starting dose. I would recommend a patient start 25 milligrams once a day with the biggest meal of the day and take that for a week until they're feeling okay. And then they'll go, for instance, we had a patient recently who started this medicine. We told them to take it once a day with their biggest meal, which I said was dinner. So they did dinner once a day for a week. Then they went to twice a day. They took their next biggest meal, which was lunch. So they did lunch and dinner for a week. And then they ended up doing 3 times a day, which is breakfast, lunch, and dinner for a week, and did that for 2 weeks. And then we monitored the effect and increased the dose from there. Okay, the sodium glucose co-transporter 2 inhibitors. They reduce renal glucose reabsorption. So they lower the renal threshold for glucose and increase the kidneys to excrete glucose. The three agents that are available are Invokana, Farxiga, and Jardiance. The most notable pharmacokinetics of these include a 24-hour half-life, and they peak about 1 to 2 hours after a dose. Their A1C lowering, again, is comparatively smaller, like the alpha-glucosidase inhibitors and like the DPP-4 inhibitors. They also nicely will lower blood pressure if your patient has high blood pressure, particularly the systolic blood pressure, by about 3 to 6 millimeters of mercury. And they can decrease weight by up to 8 pounds. The most adverse effects, as you can imagine, might be the genitourinary system. They can cause some UTIs and mycotic infections. Patients might complain of increased urination. They may cause hypotension. They may cause hypoglycemia. They can decrease LDL. They can increase serum creatinine and also cause some electrolyte abnormalities with increased urination. That's a common finding. So you're looking at maybe increased potassium, magnesium, and phosphorus. You want to watch use of these agents in patients with renal impairment. So with a GFR of less than 60, which isn't that impaired, you want to avoid avoid dapagliflozin. And for a GFR of less than 45, you want to avoid canagliflozin and imagliflozin. Other precautions to keep in mind are a potential increased risk of bladder cancer with dapagliflozin and a potential increased risk of stroke in patients on canagliflozin. The dosages are listed here, and these two are all once a day, dosed with or without food, and most patients will take them in the morning. Clocevilam, or Welchol, is a bile acid sequestrant, which is used to treat hypercholesterolemia. It was approved to treat type 2 diabetes by the FDA recently. Its mechanism of action in diabetes is it may reduce hepatic insulin resistance, leading to a reduction in hepatic glucose production, and it may reduce intestinal glucose absorption. Its lowering effects on A1C are relatively modest at 0.5%, and as we know, with using it in cholesterol agents, it decreases LDL by 20%. When using it as a lipid agent, we also know we need to monitor triglycerides. It actually can increase triglycerides. So that's one adverse effect that you want to watch out for in treating patients with diabetes, because patients with diabetes can also have elevated triglyceride levels to kind of mirror their hyperglycemia. Other adverse effects include the gastrointestinal system, nausea, bloating, and constipation. It's dosed at 3.75 grams PO once daily. They have to take 6 of the 625 tablets all at once, which can be a little bit tough to take. So you can also divide it twice a day with meals if that helps patients manage. The contraindications, like I mentioned, with triglycerides are a history of pancreatitis. Remember, if using these bile acid suppressants and cholesterol, they actually can bind some other medications. So particular drug interactions with bile acid sequestrants include levothyroxine, oral contraceptives, some iron supplements, And if a patient is also on these agents and cosevalam, you want to separate the administration times. So for example, if someone was on Synthroid and Welchol, you might want to take your Synthroid 2 hours before the Welchol or 4 hours after the Welchol. And the most common time you're going to see cosevalam used in diabetes is if a patient also needed help with their cholesterol and they, for some reason, were intolerant or could not take a statin for their cholesterol. Bromocriptine, or cycloset, is a dopamine agonist, and this mechanism of action in diabetes is really not clearly understood, but it's believed that it may reset the circadian rhythm that may reduce caloric intake and storage. Its A1C lowering, again, is fairly modest at 0.5%, and the other advantage of it is that it rarely causes hypoglycemia. The dosage is 0.8 milligrams orally once a day when you wake up in the morning and you want to take it with breakfast. And you can titrate every week for over 6 weeks to the maximum dose of 4.8 milligrams once a day with breakfast. The adverse effects of bromocriptine include nausea, vomiting, fatigue, and headache, dizziness, hypotension, syncope, and this, again, most common during the dose titration phase. So if a patient has experienced this, instead of titrating every week, you might want to extend the dosing titration to every 2 weeks or every 3 weeks or even once a month. And keep in mind that it can decrease the prolactin levels. And the contraindications and precautions are patients on concurrent antihypertensives because the risk of causing dizziness and hypotension and syncope might be greater. Okay, so I'm going to switch quickly away from the oral agents to treat diabetes to talk about one particular non-oral, non-insulin treatment for type 2 diabetes, which is the GLP-1 receptor agonists. And these are incretin mimetics. Remember, the DPP4s are incretin enhancers, and the DPP4s enhance endogenous incretin. These GLP-1s are actually agonists. They increase glucose-dependent insulin secretion. They decrease postprandial glucagon secretion. They slow gastric emptying and promote fullness. The three that are available are extenditide, which is immediate release by ADA, and extended release by Durion, Victoza, and Tanzium. The pharmacokinetics, the notable pharmacokinetics include extended release formulations, and the steady state might not be reached for up to 6 to 8 weeks. So telling patients that they're not going to see a full effect in their blood sugars for up to 2 months. So the efficacy is significant. And it can lower A1Cs by 1 to 1.5%. It might be slightly higher with the liraglutide. And weight loss, up to 3 to 6 pounds. The most common adverse effects with this drug class include headache and gastrointestinal side effects, which include nausea, vomiting, and diarrhea. Less common adverse effects include pancreatitis, renal insufficiency, or acute renal failure. Contraindications and precautions include patients with gastroparesis, and the rate and extent of other medications and absorption may be affected. And you want to use precaution and be a risk that thyroid C-cell hyperplasia may be increased with patients on these medications. And again, another benefit here is that patients are less likely to get hypoglycemia when they're using this as monotherapy. So Byetta is dosed 5 or 10 milligrams subcutaneous twice a day. The Bidurion is used 2 milligrams subcutaneous once a week. Victoza is dosed 1.2 to 1.8 subcutaneously daily. And the Tanzium is dosed subcutaneously once a week. So you have some options, a daily and a weekly option. Okay, let's take a step away from the glycemic treatments to talk about glycemic targets. So the ADA generally recommends a target A1C of less than 7% and a fasting or pre-meal glucose of less than 130 and a postprandial glucose of less than 180. The 2012 treatment updates recommended using a patient-centered approach to A1C targets, and that maybe a less than 7% doesn't fit everybody. So they recommended that you might consider a more stringent goal. For example, an A1C of less than 6 or 6.5 for some patients, and maybe a less stringent goal, an A1C of less than 7.5 to 8 or even higher in some other patients, particularly the patients that are most at risk of hypoglycemia or hypoglycemia unawareness. So this picture depicts the elements of decision-making that might go into play when you're picking either a more stringent or a less stringent goal for a particular patient. And the left-hand side here talks about some of the patient characteristics that you might take in consideration when you're picking a more stringent A1C goal, for example, of less than 6 to 6.5. And they might be patients who are very highly motivated. They're very adherent. They have excellent self-care, capacity to follow your recommendations. They have a relatively low risk of hypoglycemia. They are newly diagnosed or new in their type 2 diabetes journey. They have a long life expectancy. They're usually young in age. They don't have a lot of comorbid conditions. They don't have a lot of microvascular complications or macrovascular complications, and they have the resources and the support system to be aggressive in managing their diabetes. On the other side of the picture, on the right-hand side, are some elements that might have you target a higher A1C goal in some patients, and those might be patients that you can be the opposite of the other side, and that these people are less motivated, they're generally not adherent and have poor self-care capacity. They are high risk of having hypoglycemia. So being really aggressive, you generally run the risk of having a potential for more hypoglycemia. So patients who have that risk of being hypoglycemic, you might not want to be really aggressive. Patients who have long-standing diabetes, patients who have a relatively short life expectancy, patients who have a lot of comorbidities, and already have a lot of long-standing complications of diabetes that generally are irreversible, those are patients that you might want to have that higher A1C goal. So it's very important to individualize your A1C goals for your patients, and as you pick your therapies, you keep that goal in mind. So treating with the target in mind. It's a review that the higher the baseline A1C, the larger the absolute decrease compared to a lower baseline A1C. So you have some patients who are newly diagnosed with diabetes and have maybe a diagnosing A1C of 11, and you start metformin and you expect an A1C lowering of 1 to 2%. They might actually go above that at diagnosis because it's so high. Again, in absence of contraindications, that being a GFR of less than 30 mLs per minute, metformin is the preferred first-line agent for treating type 2 diabetes. The most common oral additions to metformin include a sulfonylurea because of its relatively strong effect, lowering A1C by about the same as metformin, 1 to 2%, and its low cost. Or the DPP-4 inhibitors because of their high tolerability. Keep in mind the one combination that should not be used together are the sulfonylureas and the beglitinides because, again, they're both secretagogues. They're both working in a similar mechanism, and the combination doesn't make as much sense. If you have a patient on a maximum of 2 medications and their A1C is less than 9 and your goal is still around 7, adding a third oral agent is an option. But if you have a patient on 2 meds and their A1C is still significantly high, for instance, a goal of 7 and their A1C is still above 9, your third oral agent is unlikely to get you to goal, and then you need to consider particularly adding a basal insulin, for example. So there's no clear prescriptive recommendation on which agents to add to metformin, but it should be patient-centered, and it should be based on how far away they are from their goal once they're maxed on metformin, the drawbacks and the risk of side effects and risk of hypoglycemia, and the cost. And so this table is really helpful when you're asking the age-old question, I've got someone on metformin, and what do I add next? And the answer is, it depends. Starting from the top here, the insulin, the sulfonylureas, and then GLP-1 agonists have the potentially greatest effect on A1C lowering. The meglitinides and the TZDs and the SGLT2 inhibitors are next. And then the relatively less effect on A1C are the DPP-4s and the alpha-glucosidase inhibitors. The side effects here, in addition to the side effects, you're looking at oral versus injectable. And the cost. I mean, I think of currently in diabetes, there's a huge range in cost. It's either really cheap or really expensive. And currently now there's not really a middle of the road. So that's particularly helpful, I guess, when you're either picking one extreme or the other when you're looking at cost. Okay, this slide, again, highlights a little bit in color. This is from the ADA 2012 recommendations, and kind of highlighting the same areas for each medicine that I mentioned. With all patients, you can look at healthy eating, weight control, increased physical activity, all the lifestyle modifications that are important with diabetes. And the more and more I help manage medicines, the more I learn that if patients don't change their eating and try to lose a little bit of weight and move a little bit, all these medicines are going to be hard to control their diabetes. So metformin, drug of choice. The second choice of adding to metformin are sulfonylurea, a TZD, a DPP-4, a GLP-1 receptor agonist, and insulin. And so, for example, on the left-hand side, if you decide to choose a sulfonylurea to add to metformin, and you, again, wait 3 months and you're still not controlled, then they also give you, on that column, some other choices. So you're maxed on metformin, you're maxed on sulfonylurea. Your choice on the left would maybe to add a TZD, add a DPP-4, add a GLP-1 receptor agonist, or add insulin. If you add a TZD to metformin, the choices for the third agent could kind of be in order. Either look at sulfonylureas, then a DPP-4, then a GLP-1, or insulin. If you have someone on metformin and a DPP-4 and they're not controlled, you can add a sulfonylurea, a TZD, or insulin. If you have someone on metformin and a GLP-1 receptor agonist, you can add a sulfonylurea, a TZD, or insulin. And then a metformin and on insulin, you still can go back to add an oral agent if someone's on insulin. You wouldn't add a sulfonylurea. You would maybe try to add an insulin sensitizer like a TZD, a DPP-4, or a GLP-1 receptor agonist. We get the question all the time is, once somebody is on insulin, do they still need to be on a sulfonylurea or a meglitinide? And the answer is it depends on the dose of insulin. Usually when you're starting the dose of insulin and the requirements are relatively low, we'll keep the sulfonylurea or the meglitinide on board. And once the insulin doses increase and the blood sugars start to improve, we will discontinue the sulfonylurea and the meglitinide. And this slide is a review of other important diabetes quality measures. I'm sure all the primary care physicians out there will know that these are the measurements of your care that you will be graded on, including A1C goals, LDL goal, LDL less than 100, the 2013 lipid guidelines that were published, and they actually recommend all type 1 diabetics or type 2 diabetics between the age of 40 and 75 who have an LDL of greater than 70 should be on a statin. And again, all those of you who have read those cholesterol guidelines actually don't give you a goal less than 100. They say you should just be on a statin. And then the thing to measure is what is their 10-year cardiovascular 10-year risk. And if their 10-year risk is equal to or greater than 7.5%, they should be on a high-intensity statin regimen. which would be Lipitor 40 or 80 milligrams, or Crestor 20 or 40 milligrams. And if their 10-year risk is less than 7.5%, they can be on a moderate intensity dose of a statin, which would be Lipitor 10 or 20 or Crestor 5 to 10. Blood pressure goals of diabetics are very important, and the blood pressure goals have been slightly increased. Blood pressure should be less than 140/90. And a common quality measure used on pharmacy benefit plans are patients who have diabetes and hypertension, which percent of them are on an ACE or an ARB. You want your patients to quit smoking, and you want all patients to be on aspirin if indicated. So I want to review this case to kind of highlight all the patient characteristics that you would need to look at when you are looking at a drug combination for a particular patient. So MC is a 43-year-old obese male with type 2 diabetes that was diagnosed 6 months ago. He's currently on metformin, a gram twice a day. He's tolerating it okay now, but he did have some gastrointestinal complaints during the dose titration. The A1C at diagnosis was 8.1, and today it's 6.8. His other medical conditions include hypertension, which is controlled on lisinopril 10 milligrams daily. He has good medication insurance coverage. He is motivated and has family support to control his diabetes, and weight loss has become a particular priority for him. And in the chart, in our health centers, we practice a lot of team-based care, and we all kind of work off the same electronic health record. So the PCP clearly in the chart has documented that her goal for this particular patient is a more stringent goal of less than 6.5. And again, looking at the slide I mentioned previously, we have a young person, newly diagnosed. He's motivated. He doesn't have a lot of concomitant diseases or complications that would prohibit him from aggressive management. So all those factors played into him having a more aggressive A1C goal. So what agent might be the best choice to add to metformin for this patient MC? The first choice is glipizide. Second choice could be pioglitazone. The third choice is sitagliptin. The fourth choice is extenditide. Or the fifth choice is a basal insulin injection at night, for example. So we're looking here back at this table, and we already have him on the drug of choice, metformin, and we've titrated up to the max dose of a gram BID. And so our next choice is to look at which of these choices would be the best choice. So the first question is, what A1C lowering do we need? This patient only needs a 0.3% lowering. His goal is 6.5. He's at 6.8. So all these choices do that. He's pretty close. The side effects. He wants to really avoid weight gain. He's obese and he's trying to lose weight. So you want to pick, maybe thinking about if all these agents are going to get you to your goal, then you might want to pick an agent that doesn't cause weight gain. And of those choices I listed, the sitagliptin, the DPP-4, or the GLP-1 agonist is not going to cause weight gain and may actually cause some weight loss. Cost is no limitation at this time, but again, looking at the sitagliptin and extenditide, those two are fairly expensive. The best choice today for him would be the sitagliptin because it's, again, very well tolerated, it's oral, and you really only need a small A1C reduction for him. But what if his A1C today had gone up to 9.1 instead of 6.8? I don't think sitagliptin would be the best choice in that case because, again, the DPP-4s, they're tolerable, they're oral, but they do not have a very robust lowering of A1C. So using sitagliptin would not get a patient with an A1C of 9.1 down to 6.5 unless he had a significant lifestyle or weight loss reduction. In that case, you might want to try the extenditide. Okay, and the references I listed here include the ADA diabetes treatment guidelines of 2012, and some other references here.